call this meeting to order. Into 24th. And Christine has done a sound check, and if anyone experiences difficulties during the meeting, please reach out via chat. So we acknowledge and respect the Indigenous peoples within whose traditional lands we're living today. We move to the adoption of the agenda. Recommendation is that the June 24th SB Development Hospital Board meeting, the agenda be adopted as circulated. Oval and second by Director Alder. And welcome. We've got one alternate director, I believe. No, two. One in person. Director Schmidt, welcome. And Director Rhodes online. Welcome. Okay. Yep. Right. No, and I was just that. I'm too quiet. Okay. All right, where's the speaker? It's right about here. I'm usually not quiet. All right, I'll have to yell. It's right there. Yeah, I know. That's why you shouldn't have an issue hearing me. No. All right, and so the adoption in the minutes, the recommendation is to adopt the March 25th, 2026 hospital board meeting minutes. Cunningham, seconded by Director Pawpaw. Any discussion? All those in favor? Motion is carried. And then the executive committee meeting minutes are received for information only. So this evening we have two delegations. The first is from Tyler Doby from the Victorian Hospital of Castle Auxiliary Society. He's going to be speaking to us on long-term care expansion and integrated health infrastructure planning. Welcome, Tyler.
Thank you very much. And thank you for allowing me to appear before you as a delegation from Caslow. My name is Tyler Doby. I'm president of the Victorian Hospital of Caslow Auxiliary Society and chair of our hospital expansion committee. VHKAS was instrumental in getting Caslow's first hospital built in 1903. For the past 2 years, I've been working with fellow volunteers for an expansion of long-term care services at Victorian Community Health Centre in Caslow. This is not a new issue. In the late 1990s, government planning studies identified a need for more long-term care capacity than exists today. While a phase 1 construction was completed in 1999-2000, a subsequent phase that had been planned and anticipated was never realized. Today, the Victorian Community Health Centre includes 18 long-term care beds, 6 of which remain in shared rooms. 2 beds are designated for hospice care. At the same time, Caslow and Area D have one of the oldest populations in the region. According to the 2021 census, approximately 34% of our population is over the age of 65. Our auxiliary has been supporting healthcare in Caslow since 1902. When local women partnered with the Victorian Order of Nurses to establish what became the first VON hospital in Canada. For more than 120 years, community members have stepped forward to support local health services. Today, our volunteers continue that tradition through the operation of the VCAS thrift store, putting in thousands of volunteer hours each year. The revenues from our thrift store provide support for long-term care residents, community wellness initiatives, and bursaries for local students. We pay to maintain the gardens of the long-term care residents and contribute to the activities budget, which includes live music. Last year, wheelchair accessible garden boxes were installed so that residents could participate in the gardening if they wish. And this year we have approved funding replacement of the outdoor furniture. In our advocacy role, over the past 2 years, we have engaged constructively with Interior Health and provincial representatives regarding the future needs of our community. As a result of those conversations, Interior Health has applied for funding to undertake a comprehensive planning and feasibility study, examining what an expansion of the Victorian Community Health Centre might look like. While that decision is pending, our community has begun thinking more broadly about what the future could be. What has become clear is that long-term care cannot be considered in isolation from housing. Kaslo has experienced an extremely low rental vacancy rate for many years. Seniors often have few opportunities to downsize within the community, while employers struggle to recruit and retain workers because housing is unavailable. As a result, we're exploring a broader vision that would integrate expanded long-term care, assisted living, independent seniors housing, workforce housing, and a shared community space into a coordinated development connected to the existing long-term care. The existing VCHC site presents interesting possibilities. Significant land is currently occupied by surface parking, and preliminary discussions have explored how more efficient use of the site could potentially accommodate both expanded care services and residential units. What inspired this broader vision was learning about the Fairview Gardens project in Nelson. The partnership between Golden Life, Columbia Basin Trust, and Interior Health demonstrated that creative partnership models can successfully deliver important health infrastructure while leveraging the strengths of multiple organizations. At this stage, there is no defined ownership model, no formal project structure, and no specific funding request. Our purpose today is simply to provide early awareness and to ensure that the West Kootenay Boundary Regional Hospital District is part of the conversation from the beginning. Should the planning study proceed, and should a viable project emerge from that process, there may be future opportunities for regional partners to play a role. For now, we are focused on community engagement, partnership development, and building a shared vision for the future. As a follow-up to this presentation, I will send members of the board a copy of the discussion paper that we have been circulating around the community and a link to a 24-minute talk that was given at the Aging Together Summit in May, both of which will outline this vision in more detail if you are interested in learning more. The results of our survey will be available soon. I appreciate the opportunity to brief the board and would be pleased to answer any questions.
Thank you, Tyler. Are there any questions for Tyler? See any in the room and no one online. So thank you very much for your presentation, Tyler, and we'll look forward to seeing the materials. Have a good evening.
Thank you, Chair.
Our second delegation is from Betty Brown from the Jim Pattison Center for Health and Systems Learning. Welcome, Betty.
Thank you very much. It's my pleasure. Am I correct in assuming you're going to help me out with my PowerPoint slides?
Christine will do that, yes.
Great. Excellent. I must give kudos to the previous delegation as another fantastic example of community action and collaboration that's necessary to improve health and well-being. So it's great to ride on your coattails. My presentation today will be brief. I'm here to let you know that our organization exists, we're new, and we're unique. So I represent the Jim Pattison Center for Health Systems Learning and Innovation. Before we advance the slide, I'll show you here our new slogan, where good ideas become better healthcare. I would like to amend that right off the bat and say, where your good ideas become better healthcare, and I'll explain in a moment. Next slide, please. So I represent an organization that is the first of its kind, social enterprise for-profit model with a single shareholder. And the purpose of our social enterprise is to improve health and well-being. And we do so because we have a unique space. We work in between the healthcare system and patients and partners. Many of us have worked inside the healthcare system, but the Jim Pattison Center is independent and nimble, and we believe, a neutral convening space for innovative ideas to be presented to the center to improve healthcare. And essentially, we go from idea to impact. We're able, because we work outside of existing healthcare systems, to test good ideas. We also work with the healthcare system. In fact, the CEO of IH, Sylvia Weir, is on our board. We work with the healthcare center as we test new ideas to ensure that if uptake is necessary with the healthcare system, it will be done properly. So we're independent. We moved from idea to impact, and we were co-created, came out of the health authority with one of the leaders. Our CEO, Dr. Deanne Taylor, was the corporate director of research at Interior Health, and she envisioned this new way of being as really a very unique way that the health care system could improve. Next slide, please. So we have a ton of international network connections. We have a lot of academics on our staff team. We have access to industry and angel investments and know of various funding sources. We can act for a given project in a different way. So some ideas are small and we help build them out. Others are pretty much established, but they need either a funding partner or an evaluation piece. And other projects are people that come to us and say, do this for us. We really think this is worthy of being tested. And so we have a pipeline through which various projects and ideas come, and they come in all different shapes and sizes. And the center can help with anything like that. We can refer people to funding sources, convening and supporting letters. We can do the work if need be, and we facilitate working agreements, among other things. Next slide, please. So we are community-led. I neglected to mention that the formation of this was through the KGH Foundation, Interior Health, multiple community dialogues, conversation with all 7 First Nations and Métis communities to really help shape this entity that we call the JP Center. There's a lot of roles that we can perform to support innovation. Next slide, please. So here, we are not quite a year old. The center began officially on paper the day after Canada Day last year. And to date, not only have the staff been hired and the processes been put in place, we've had a total of 65 submissions received from all kinds of partners in the community and nationally into the system for us to assess and innovate. We have 22 are under review, 11 projects are functioning actively now, 26 are on hold, and those can be from everything like, oh, they need to see if they've got a funding source, or they're waiting for their final signatory to sign on for a partnership, etc. And we've declined 2 of those 65, and 4 are complete. And the very tiny print at the bottom of your screen there, it's the same 65 programs, but they're just issued by the Canadian Institute for Health Information KPIs in topical areas. And we have 6 advisory tables that are beginning to take action, and they contribute ideas. So that's really where and how these ideas that we've received to date have come. They can come from somebody as individual, as a counselor with a very tiny community like Lytton, to, as I've said, a national organization. Next slide, please. I'll just buzz through these. There's a couple of examples. We have an app that's being tested as one of those 65 ideas. Instead of somebody with diabetes having to input every ounce and portion of their meals, this app is working with a photographic system where you can take a photo of your plate, morning, noon, and night, and it will assess and determine how well you're eating to support your diabetes regime. Next slide, please. And Lilo Health is a similar project, but that's been underway for some time, and it's in Kelowna. It's like a wearable, but it's not a wearable. But this system enables the wearer or the person in which in whose home the device is, to be monitored. And it does all kinds of cool things, not just their personal blood glucose or heart rate or blood pressure, but also things like how often the fridge door opens, how much sleep they're having. So a third party, like a child, adult child of an old aging parent, will be able to monitor their parent. So that's just a couple of ideas. Next slide, please, of the kinds of projects that we have. But as I say, they're very, very diverse. So again, the JP Center is a new entity. I was hired exclusively to spread the word this year to all local governments in the Interior Health Region. We will expand throughout the province, but the purpose is really, I call it an equity focus, to make sure that every local government knows we exist, know that you are invited as leaders in your community to start to think, oh, what if? How could we take advantage of this system? We know the wicked, gnarly problems in our communities. And where might some innovative idea come from? You may have a problem in need of a solution, or you may have an innovator in your community that's already come up with some new way of addressing transportation or appointment management systems or what have you. So the first message from the center is we exist. We welcome input from rural communities, and we're not going away. And over time, we hope to work together with local governments and communities to do things that help you take advantage of the JP Center. Next slide, please. Before I explain how you can help, this is on our website. We do have a pretty dense website that you could have a look at to get a better sense of who we are. I've also forwarded an electronic FAQ booklet that I hope you all have to follow up with at your pleasure. And the last thing I'll point out here is that we have a drop-down menu on the toolbar of our homepage where anybody can submit an idea. All of you could submit an idea tomorrow. There's a pretty loose outline there, and it will guide you. And if it's something that you will, regardless of the scope of it, you will be contacted by somebody from the JP Center who will follow up with you and do an intake. Essentially, the JP Center at present is able to give up to 5 hours of in-kind support to any project to help it become developed and to move through the innovation pipeline. I know it's all sounding somewhat abstract, but we're here to help is the short term. Next step, or next slide, please. So I'll mention actually a couple of you in the room, Mayor Frank Marino and Councillor Aidan McLaren Coe have joined a very small time limited rural engagement and advisory committee that I have formed. And the goal of this group is purely to find out how to effectively work with local governments across the region. We have a First Nations representative and members from SOGA and AKBLG, et cetera. And we're really essentially saying, help us help you. What can we do at the JP Center to help local governments and by extension their communities to engage effectively and collaboratively and to perhaps think differently about how healthcare is managed? Next slide, please. Oh, this will be quick. Our JP Center will be present at the UBCM convention. Two of us will be there. This is our CEO, Dr. Deanne Taylor. Unfortunately, she will not be able to be there. She is slammed. I'll be a delegate. We'll have a trade show there. We have an in-person meeting for the aforementioned rural local government group. And we are hoping to have a clinic that I invite you all to consider. If we are accepted, it will be the first of our rural health innovation local solutions clinics, where we'll start to convene together about some wicked problems that are similar across the board for people in rurality. I think that's it. Final question, please, or final slide. Yeah, so while I rest on this slide, feel free to sign up. We have a quarterly newsletter. Oh, if you could pop it back to the QR code, just in case people are interested, although you guys all have probably a copy of this. But this QR code will take you to a sign up for a quarterly newsletter from the JP Center. We've had 2 so far in our iteration. We do monthly virtual coffee chats that anytime, anywhere, you can call in for a half hour or an hour meeting with us. It's a no agenda, team focused way of engaging with people who are curious about us. So with that, I will return the mic back to the chair and ask if there are any questions.
Thank you, Betty. We do have 2 questions. We have 1 in the room so far, and now 2, and at least 1 online. Director Jackman.
Yeah, thank you through the chair. Yeah, Gary Jackman here, Betty. It was great to see you again. As I
Too.
Phil, if you spend too much time in the cookies, you never get to retire, and obviously that's the case for you.
Exactly.
My question was to understand a little better, because you've this entity is formulated as you said, for profit. So it's kind of double question here. I'm assuming that you can work with entities that will make a profit. You know, you show them a couple examples, develop a product, sell it, and be profitable. So then would your enterprise for a period of time derive a percentage of their profits? And then if you did that, is that for the purpose of reinvestment to support your core?
Yeah, that's a great question. And although I can't describe it in minuscule detail, there's a variety of ways that we will get profit. I don't know if it's, I believe it's from any grants that we get, we'll take a small portion. I know that there's some project management fees that we might earn if people are asking us to manage the project. And innovation and innovative projects that have a revenue generation source, and we've had a major role, we would take some small percentage of that as well. And you've very correctly identified something that I think I forgot to mention, but we got a $5 million naming rights grant from Jim Pattison. That was the end of his association with our organization. He gave us the startup money, essentially. It came from Jim Pattison's foundation, and he is not in any way receiving any benefit or profit from what we do. The foundation, though, has expressed interest already in some of the projects that are coming through our pipeline that they may want to fund. But in terms of the profit, any profit incurred by the JP Center will go right back to the Kelowna Foundation, Kelowna Hospital Foundation, and they will regenerate it back into the work of the JP Center. So it's a full circular model. We're not all going home with big bank accounts after this. Is that clear?
So that's just as presumed, because Jim Pattison doesn't need any additional revenue streams. I was certain. Oh, thanks for that.
Okay.
Director Watson.
Yeah, thanks. I have a couple questions, and then Chair, at the end, I missed your Q&A for the previous delegation, and I see Tyler's still here. If I can ask him a question when this is done, your call. But my 2 questions for the current delegation.
So go ahead with your question.
Sorry. You mentioned a single shareholder. Who's that shareholder?
The Kelowna Hospital Foundation.
Okay, thanks. And how is personal data that's collected through these systems, or whatever the devices are that you mentioned in the presentation, how is personal data being protected?
I don't have the details on each project. I'm not even at liberty of sharing all the projects that we have, but I can definitely put you in touch if that is an area of your interest or expertise. I'll put you in touch with the project lead.
Thank you. I don't think I need it for this moment, but I would just say that if you were ever seeking funding from us, I'd have a lot more questions about the funding model and how things like data are protected, but I don't need it in the interim.
We are not seeking funding.
Okay, thanks.
Yeah, okay, thanks for clarifying.
Director Papa.
Yeah, thank you, Chair. Through the chair, I did meet you at AKBLG and Trail, and did have a conversation with you. some of the directors are not lacking ideas how to improve the healthcare system. And some of the ideas might not generate any funds. Where does that go, and where do we fall? Like, for example, if a director submits an idea, who follows through on the idea? How long is the directors involved with that idea and follow up on it? And if it doesn't generate any funding for the Jim Pattison Group, will that be followed?
I'm finding you're a little hard to hear, but see if I got it right. I think you're asking if, you in your lived experiences are not short of things that could be improved upon regarding healthcare. And if you come up with an idea and you don't have an innovator to work with you, are you wondering if that is still an acceptable project to submit?
That's one part of the question. The other part of the question is if that idea does not generate any funding for the Jim Pattison Group or anything else, it's just a change in the system.
Right. Oh, no, that would be totally fine. It's if there's some kind of staffing cost or huge number of hours that the center puts into that, we can put innovative ideas through the system very quickly, and they don't have to be a for-profit concept. And the other thing that is niggling for me is there's a number, I believe, of communities that may well have a ton of really wicked problems, and they may not know how to think differently about them and have the advantage of innovators or entrepreneurs to help create a solution to that. And I am in the process of meeting with business people and like angel investors and such to determine how early in a process we can get business people into the pipeline with communities to help flesh out a project that can actually take off and be sustainable. So what the Jim Pattison Center does is we take projects that are submitted or ideas, helps get them to a point that they can be tested. And these ideas have to have the potential for high impact. There will be necessary evaluation done before they're actually implemented in the test phase. But so they have to have potential for high impact, and then following the testing from the JP Center, they have to have the potential to be scalable and replicable. In other words, we wouldn't do something that's so unique to a given community that we would test it and make sure it's perfect, but it can never go anywhere else. We have to look at sustainability and spread for the biggest bang for the buck, if you will. My role, if you ever have any questions in that regard, is this an idea or an innovation or whatever, you can always call me to start. You don't have to even submit your idea. You can just call and I can help you get started if you have something in mind, or direct you to the right person in our team. We're a small but mighty team, and that's our role, is to help.
All right, thank you very much, Beth, for your presentation. Were there any other questions? All right. Well, thank you very much for joining us this evening.
Thank you, my pleasure. It's nice to see several of you again. Have a good meeting.
Thank you. All right, Director Watson, we'll go back to you, and you can ask Tyler the question you had.
Yeah, thank you, Chair, for entertaining that inappropriate process on my part. I was not quick enough. I just wanted to first thank Tyler. He's been working on this for many, many years, as has the BHKS. My question, and I'm sorry if I missed this in your presentation, Tyler, but speaking of innovation, you're looking at something that's very innovative for our rural area. Where do you think the funding is hopefully going to come from? Do you have an idea of budget and or who you will be seeking for the few millions it might be? Not to say it's a good idea.
Absolutely. Because obviously if we were just looking at an expansion to the long-term care, that would be a capital project undertaken per normal. If we're looking at a housing project where Interior Health could be the tenant of one floor and we expand the long-term care, what I've been doing is approaching potential partners, value-aligned partners, So Golden Life is one example where they own half of the Fairview Gardens building. They're not the operator. It's leased to Interior Health. I got to have a good conversation with the vice president there, who's in charge of new initiatives, and he was very receptive. I've approached the Lower Kootenay Band of the Ktunaxa, and they were very receptive. The person was new in his role of investment and development. And do the housing part, I think Kaslo Housing Society would be an ideal partner. They're searching for a new executive director at the moment, and then they'll be looking at what is their next project. So, there's potential for BC Housing or federal funding for this, but I think the partners for the capital construction would ideally not be public money. It would be private, but values aligned partners. Yeah, hopefully that answers your question.
Yeah, no, it does. Thank you very much. I appreciate that. It's
Thanks.
innovative and exciting and a little daunting, but I know you guys are up to it. So thanks for the update.
Thanks.
Thank you. Go ahead.
Yeah, thank you, Chair Hewitt. Just a quick question for Betty. Thank you. Really enjoyed your presentation at Keeping It Rural. I just have a question regarding long-term care for seniors. Is that something that that the center can help us with? Is that a project that you would look at?
Well, again, remember, yes, the short answer is, of course, anywhere on the healthcare continuum, well, even into population health and well-being, all the way down to treatment, recovery, and support, primary care. What we don't do is support existing operations, but a new way to do healthcare, a new way to do long-term care in your community, or if you found something, you just think, what if we tried this, but you just don't know if it's going to work. That's the sort of idea that we would encourage you to submit.
Follow-up, Chair? Right. So what I'm hearing is you're looking for new ideas and new approaches to healthcare?
Correct. Because we know that you when you're in the system, there's so many regulations, legislations, the pressure is on, there's budget constraints, too many people, great staff, but they're all working so hard and so fast. So we're taking this breath, we're away from that system and going, okay, how do we release innovative ideas, the thoughts about what if we tried this? And we're providing a space that will enable that to happen. And we're also going to, with the local governments in our province, try to convene spaces where local governments can maybe come together to do that rather than individuals. That's not a necessity. There's no way that you have to partner with anyone else. We're just wondering if that would be effective to do innovation hubs or support local governments to determine how to have an innovative idea and how to test it and move forward.
Thank you, Chair.
All right, so we'll move on now to our delegation from Interior Health. Welcome, Lindsay and Matt. So Lindsay, I understand you're presenting this evening.
Thank you. Thanks for having us here this evening. I think you all know Matt Wilkie, and we've been working together for quite a long time now. Matt is responsible for making sure that I see the right numbers in the presentation. He's for Matt and I am. My name is Lindsay Pitu. I'm in a new role. My previous role was Executive Director in the East Kootenay region for Interior Health, and I've been there for 20 years. I'm born and raised in Cranbrook, so that's my home, and I have a great love for the Kootenays. So very happy to be here in the new role.
Can't hear.
Sorry.
Well, I'm not sure whether it's just the mic is not picking, and we're the closest that it should have a problem.
So my new role is Chief Operating Officer for the Kootenay and Kootenay boundary regions of Interior Health. Next slide, please. I'd like to start off with a land acknowledgement, just recognizing and acknowledging the traditional, ancestral, and unceded territories of the Delta-Kootenay, Ktunaxa, Inkpakwatma, Portland, Stettin, Silks, and Chilcotin nations, where we live, learn, collaborate, and work together.
I'm still the sound.
I can maybe go up and see.
Yeah, see if you can do something, 'cause it's not good if half of our board can't hear.
Gonna try. Is this any better?
That's
Yeah.
better.
That's better. Okay, so on the screen right now, just a snapshot of some current and ongoing projects by community that we'd like to just give you some updates on this evening. Next slide, please. And slide. So we're gonna start off in the Boundary Hospital in Grand Forks. First up, we have a gas oven, and the RHD contribution on that one was just over $21,000. And we estimate having that one completed by August this summer, 2026. Next up is a renovation to a washroom, making it wheelchair accessible. And that project we also anticipate completing this summer. And the RHD contribution on that was $36,000. In the same facility, we have an elevator modernization project. The RHD contribution on that one is $177,600. And the estimated completion for that one is in the 2028 year. We're working right now to get a consultant on that complicated project. Next slide, please. And still in the Boundary Hospital, we have an air handling unit. We anticipate this project to be complete in October of this year. RHD contribution is $39,600. And still in Boundary Hospital, we have our laundry air handling unit replacement. This one we anticipate completion in November of 2026, and the contribution on that one is $39,800. Next slide, please. Next slide again. So moving over to the Columbia View Lodge, we are replacing rooftop handlers. We anticipate this project to be complete in October of 2026, and unit selection is currently underway. Next slide. Moving over to the Kootenay Boundary Regional Hospital in Trail, we have our MRI suite replacement. Construction is underway on this project, and we anticipate completion in September of 2028. The RHD contribution on this one was $13,945,000. Next slide, please. And still in the regional hospital, we have a project to relocate and replace some supply fans. The RHD contribution on this one was $1,874,100. And we anticipate this one being complete in September of 2026. We'll just be doing some testing on the heating system over the summer. Next slide, please. Lots of work in the Kootenay Boundary Regional Hospital this year. The exterior mechanical room access project. This is one that we're actually going to cancel. Oh, sorry. Oh, sorry. I've got to skip. Sorry. Yeah, it's here. Going back to the Kootenay Boundary Regional Hospital, sorry. We have our CT scanner replacement, and this one we anticipate completion in September of 2026. RHD contribution on that one was $1,491,000. So overlap. So bring back to the supply fans, I think, on slide 8. This is when everything back up. Go to slide 9. Oops. I don't have that number. Okay, this next slide. Next one. There we go. back to the mechanical room. So this project was being canceled and they're actually going to be doing a new project that's more of a confined space project that's going to be submitted at a later date. The original project wasn't going to meet the needs of the facilities group. This steam plant retrofit project, this one is anticipated for completion in July of 2026, and construction is ongoing on that one. RHD contribution was just over the $1 million mark. Next slide, please. Still in the Kootenai Boundary Regional Hospital, we have a power distribution redesign replacement. This one we anticipate completion in March of 2027. Right now, we're doing procurement for the electrical consultant. RHD contribution is $39,600. And over in the Poplar Ridge Long-Term Care, replacing that dining room solarium. This was a $36,000 contribution, and we anticipate completion this summer. Next slide, please. And next slide, please. So moving over to Castlegar in the district and health center, we have a fire alarm system. This is one we anticipate completing in August of this year. We've already done the long-term care units, and now we're just working on the Florida Hospital. RHD contribution was $643,400 on that project. And in the same building, doing a heating and water distribution upgrade. Anticipate completion in September for this project. RHD contribution was $39,800. Please. And next slide, please. And next slide. Moving to the Kootenai Lake Hospital in Nelson, we have the replacement of the CT scanner in this building. RHD contribution was $1.7 million, and general contractor tender was awarded in middle June. So this one is a November 2026 completion. Next slide, please. So in the Kootenai Lake Hospital, we had a renovation to the MDR medical device reprocessing department. This one is on hold while we are waiting some infrastructure approval to proceed with the planning work. So that one does not have an estimated completion date at this time. We do have a smaller limited renovation in the same department. This one was a $37,200 contribution, and we anticipate this one will be done in September of 2026. Next slide, please. Still in the Kootenai Lake Hospital, we have a replacement of a seclusion room door, and this is anticipated completion in March of 2027. We're engaging with suppliers on this door. RHD contribution is $28,000 on that project. Next, we have humidification for the operating room. We anticipate completion on this project in October of this year, and that is a $94,000 RHD contribution. And finally, a fluid cooler for the second heat pump. This one we anticipate in February of 2027 for completion, and that one is a $271,000 contribution. We just completed a Class A estimate in June on that one, so next step will be releasing tender for construction. Next slide, please. Still in Nelson, we have a physiological monitor for this facility, and we anticipate completion on this in 2026. And we have permanent doors on patient rooms in the emergency department that improves infection control and privacy. This is a project with a $400,000 contribution, and estimated completion is December of 2027. The scope of work has been finalized and approved, and just working to procure a design consultant. Next slide, please. Nelson Jubilee Manor, moving over to long-term care. We have that electrical system upgrade. This one's anticipated to be complete this October with a $34,800 contribution. And we have some heating boilers that need to be replaced. And this one is an October 2027 estimated completion, and a $1.32 million contribution. Next slide, please. Moving over to Edgewood Health Center, we have that generator transfer switch. This one's anticipated to be complete in October of 2026, and the contribution on that one was $29,200. Next slide, please. Moving over to Inniquest, Arrow Lakes Hospital, we have that second wheelchair accessible bathroom. We anticipate completion on this project in March of 2027. We're still preparing the architect on that project. Contribution is 39,600. And in the same facility, that packaged air handler replacement, this one has an estimated completion in October of this year, and that is a $34,000 contribution. Next slide, please. Moving over to the Victorian Community Health Center, we have kitchen air handlers. This project anticipated to be complete this October with a $30,000 contribution, and steamers in the same building. August is the anticipated completion, and that is a $16,961 contribution. We're going to move now to share some great news on our completed projects. And next slide, please. So starting off with Boundary Hospital, we did replace the multi-zone air handling unit, and this one was complete in May of this year. RHD contribution was $369,200 on that. Columbia View Lodge, we have the chiller and cooling tower replacement. This one was completed in December with $527,200 RHD contribution. And in Nelson, those MHSU 10 improvements, this was completed in February of this year, and that was a $200,000 RHD contribution. Next slide, please. Going back to the Kootenay Boundary Regional Hospital, we have that digital control system modernization project. This one was just completed in June, and that was a $39,800 RHD contribution. And then followed by the bariatric ceiling lift in the same facility. This one was completed in March of this year, and that is just over $6,000 from the RHD. Next slide, please. We had minimally invasive towers installed in Kootenay Boundary Regional Hospital. That was complete in June of this year. And the RHD contribution just over $162,000 on that project. And the meal delivery system also completed in June of this year with a $366,800 RHD contribution. Next slide. Moving over to Nelson, we have the tenant improvements for long-term care. This was complete in August of 2025, and that was a $2 million RHD contribution. And then on the same building, the long-term care community clinic equipment. This one was completed in August of 2025 with a $2.8 million RHD contribution. As you know, we did have a flood in this building of August of 2025, so there was some delay in finishing our final move-in. I'm happy to say this week, we finally have totally moved into the space and all renovations have been completed. The Arrow Lakes Hospital, there was the first wheelchair accessible washroom that we completed just in June of this year. And that's a $38,000 RHD contribution. And that brings us to the end of our slides. So I just want to take a moment to thank you very much for the support that you've given us in all these projects that are really making such a difference with building boundary regions.
Thank you, Lindsay. Are there any questions? So Director Vogel has a question. Go ahead, Director Vogel.
Thank you very much. Thank you for the presentation. Through the chair, I'm just wondering if you can give me a status update on the X-ray unit at the Castlegar District Health Center. I know it was down for a period of time, but I have been away and I'm not sure if it's been repaired.
So the current unit is at end of life. It has been repaired, but we know that it's not a reliable unit. So what we've done in the interim is purchased a portable unit, and the cost on that one was just under $300,000. It gives really nice digital images that can be used while we're kind of waiting for a longer term replacement. And so we do have a longer term replacement sitting waiting for approval through our capital process. If it got approved tomorrow, the issue is it's about an 18-month time frame before it would actually be done and installed. So I think the physicians are happy that we have that portable that they'll be able to use to continue service and keep the current unit going as long as we can.
Thank you very much. That is good news. And I appreciate that there is a long-term plan in place. I know the doctors were very concerned about it. So I appreciate it. Thank you very much.
Any other questions for our delegation of Interior Health? It's also involved presenting, you don't have any questions. Okay, so we'll move on to our business arising out of the minutes, and that's the expenditure and borrowing capital bylaw. The recommendation is that the board refer the West Kootenai Boundary Regional Hospital District capital expenditure borrowing bylaw 439/2023 to the March 2027 board meeting.
I think we've moved that recommendation.
By Director Jackson and Director Hanegraaff. Discussion. I'll go with anyone opposed. All right. So then the next item is just receipt of the letter of support for the White Mountain Health. It's just received for information. We don't need a motion on that. Thank you. That's what it. And we don't have motions on this. Yeah, so no motion already. It's just been received, and that brings us to my report. Thank you for allowing me to be your chair, and I wanted to thank the members of the executive committee for attending the meeting to discuss our priorities for the UBCM meetings. Because the deadline for submission was prior to this meeting, we had to just move forward with them as the executive committee had brought them forward. And a further thank you to the individual members of the executive committee who worked with Christine to put together the package and submit information and bring the ideas forward. Thank you very much for doing that, and hoping to see all of you at the meetings in September, and hopefully we get meetings. That's the first step.
Yeah.
So first step. And we'll move on to accounts payable. That report has been received. And that brings us to the priority topics. Really. Those who don't have their computers in front of them or paper, the first was regional strategy for rehabilitation of homelessness and public safety. And that one was jointly brought forward by, was that the one that was the three communities? So yeah, we've got City of Trail, City of Nelson, and Caspar. So did any of you want to just give a brief outline for that?
Well, thank you, through the chair.
I'm winging it here just so that the rest of the board knows what our discussion topics are.
And I'll wing it too.
You did a good enough job on the executive committee.
So, a year ago, the mayors of Trail, Caspar, and Nelson through a resolution at the AQBLG for a tri-city almost treatment facility for the homeless. And I used the wrong words. I apologize. I don't want to offend anybody. They thought it was better if they did a regional approach instead of doing like one in each city. We know the province doesn't have any money, but it had to come forward because we have to start somewhere. So they went and it was passed at AKBLG, went to UBCM, it was passed. And they're still working on it. And I was able to forward Christine some information from Mayor Jones from the City of Trail. I don't think they've moved any further. The City of Trail met with Josie Osborne, Minister of Health, the weekend of AKBLG. And she thinks it's a great idea, but she was very respectful. And she said that there isn't a lot of money at this point, but don't give up, keep moving forward. And when we were talking at the executive meeting, it was more of a, let's keep the information going towards province and let them not forget that we want to do this as a 3 community project. How's that going?
And so Director Watson has a question. Go ahead, Director Watson.
Thank you. And I see it was Director Martin speaking. I couldn't tell who you were by your voice. What I'm wondering is our Rural Affairs Committee at our last board meeting for the Central Kootenays had a conversation regarding homeless encampments and all of the varied reasons why people might end up there. But the rural areas are seeing this in terms of those unregulated FSR campsites that are what they are, but they are generally unfortunate and due to the reasons for this current conversation regarding what you might bring to UBCM. So what I'm wondering is if there is a way you can include that as part of the rural impact to support your efforts.
Well, the submission deadline has passed, but if we, we can certainly see if we can bring that into the conversation if we get a meeting. So that's all I can say is that we will try to raise that if we have the opportunity. Director Mark?
If I may, through the chair, regional district Kootenay boundary is going through this same situation about 7 Mile Dam.
Yeah.
So chair is sitting right across there and she can help me if I miss up there. But we're sending a letter to the province for eventually or 4 service roads, ones that we're not allowed to, they're out of our jurisdictions. They're in the middle of nowhere. We need some help. We've had 3 fire deaths in the last couple of months up in this area. And we need something done because there's an encampment up there that's growing near the 7 Mile Dam. And Director Watson, it's the same situation all over the place.
The worry of fires.
And I was just going to say that with the fire season coming up, thank God we're supposed to get some rain this weekend. It's drying out there quite quickly, and we want something done. We need to move those camps out of the way. And this is just one camp, and it's in the RDKB. There's camps all over the place. So we're hoping that this will bring some awareness and some movement on trying to clean up those camps.
Thank you. And our next item was raised by Director Page, who is not on the meeting tonight. I haven't seen him join the meeting. And then our last one is virtual care, which is being tested in a few communities, and Director McLaren-Coe raised that item. Director McLaren-Coe, did you want to just give a brief synopsis?
Sure, thanks, Chair. As you may know, there are 4 communities in the province that are undertaking this virtual pilot right now, where they have doctors staffing one of the 4 hospitals that attend the patients virtually in other hospitals when they have a nurse on site. And we've had success with it here in Nakusp. And we are advocating that they continue to use that and make it permanent from being a pilot, and expand it as necessary to avoid ER closures, which we have had in the past. And this has curtailed quite a bit of that. So yeah, I'm happy to support that one.
Director Watson has a question.
Yeah, thanks through the chair too. If Director McLaren-Coe has the answer, that'd be great. I don't think this is how it works because I'm pretty sure we're doing this in the Lardo Valley right now. It might be a community-based endeavor or it might be this one. My question is the virtual support an actual person or is it like a chatbot?
Through the chair, it is a doctor. I have used it myself for my kids, and they have nurses on site, but then doctors through an iPad or an iPhone that they can work with.
Great, thanks.
And we also have Director Main. I have Director Main online, and I'll go to Director Jackman.
Yeah, thank you. Through the chair, I fully support this virtual care model. I want to note, however, that at least one hospital, that one being in New Denver, has had 2.5 years of closures now because of nursing shortages, not because of physician shortages. And so at some point and in some fashion, I would like to see that addressed as well. Thanks.
Director Jackman.
Yeah, and through the chair, maybe you know this, or maybe it's something to bring up because I understood you'd need additional training for the nurse on site, and in some cases, additional tools were recommended. It seems to be ultrasounders, there's a few specific tools that the physician doesn't want to be operating blind based on just what's observed. So is that all going to be rolled in conversation, or Lindsay, you probably know that stuff. It's not just having a virtual connection, we need additional training, additional tools. Otherwise, it's not a meaningful consultation. And the last thing you want to do is miss something because you didn't have the tools.
Are you comfortable
I
answering
answered that question. Thank you.
To that. It's okay.
Yes, Carla.
So the program is called LinkED and it is something that is very innovative that the health authority is doing. It kind of originated, originated through some challenges, particularly in the north and then as well in Wisconsin. So there's 4 facilities that are taking place, and it is a voluntary physician group who agree to do it. There is some additional equipment required to make sure that the video link is accessible and working back and forth. And there is some additional training for the nurses who participate in the program. Overall, it's gone very well. I know my hospital's had a really great experience with it. So, but there is some additional training for the nurses. There is some additional equipment that was included in this pilot.
So I guess the point would be, maybe we won't get in sight with all of the activity and equipment, but to put an emphasis on the training, maybe a year or more in advance, so that if other funding comes, at least there's a trained person in every potential site, because that's probably the best place to start this training.
If I could have one more thing. There is a physician always on call in the event that someone comes to the emergency department that cannot be managed by that virtual care. So if there was a car accident or something that really needed an on-site physician, there's someone they can phone. That's great.
Well, thank you. We're at 7:02, and that brings us to public time. Are there any members of the public that have questions that they'd like to ask or Valley Voice? Raise your virtual hand. You have a question? All right, one last time. Got a question? Then the recommendation. Well, the meeting is now adjourned at 7:02. Thank you, everybody, for making the trip. We go over.
Good night, everyone.
Bye.
I know.